everyone to the. Okay, right. Okay. Welcome everyone for the International Ophthalmic Conclave virtual meeting conducted by All India Ophthalmic Society. And first of all, I like to thank on behalf of the College of Ophthalmologists of Sri Lanka to All India Ophthalmic Society for giving this opportunity, especially Professor Namrata and the others. And then I appreciate all these speakers who volunteered to present us or take part in this meeting from Sri Lanka. And I will start my talk first. We will be having four people, four speakers, myself, Mangala, Chamira, and Amila. And we each will be spending about 20 minutes. And at the end of the 20 minutes, or at the end of the talk, we will be allowing the audience to ask any question, or audience can text the questions, and I'll read up the questions for the other speakers. And then once 22 minutes pass, then we'll have to shift over to the other speaker. And if there are more questions, we'll have to stop the questions once the time is passed, that is about 22 minutes. And then the questions will be, those questions will be entertained at the end of the presentation if the time permits. So we are given 1.5 hours for the talk. So I'll start my talk first, and then followed by Dr. Chamira, and then Dr. Mangala, and then finally Amila Garatna. Okay, now I'm going to talk today. Can you share on? Can you see my screen? Can see my screen, everyone?
Yes.
Yes.
Okay, good. Okay, so I'm going to talk on how to prevent the post-cataract surgery dysphotopsias. So what post-operative cataract dysphotopsia means? You get abnormal images or disturbances, unwanted which due to unwanted retinal images following cataract surgery. This can be divided into positive and negative dysphotopsias. Whatever it is, when you do a very successful cataract surgery and 6/6 vision, and when the patient complains of, shadows or excessive brightness and all that, the patient is not happy at the end, and we are not happy. But this is not due to a complication of the cataract, but because of an inherent or unexplained the problems or reflective problems in the eye. And I'm going to talk on what those things are. One is you can categorize this into positive and negative dysphotopsias. The positive dysphotopsias means glare. And if you see these images, you can see a glare or light streaks and arcs or rings and halos, especially in the multifocal IOLs, or starbursts and flashes. The positive dysphotopsias are not very serious, and those are seen especially daytime and in the scotopic conditions when the pupil is smaller or constricted. But generally, the patients are not disturbed very much with this positive dysphotopsia because it's a little bit of a brightness on a side. But on the other hand, the negative dysphotopsias are quite cumbersome, and the patients are not happy most of the time. The commonest type of negative dysphotopsia is the arc of a shadow on the temporal side. This is the most common type, and roughly about 30 to 40% of the people, percentages of people, you get this problem, especially on the first week of post-cataract surgery. And this is generally tend to be last, and that is more common especially when the light coming from the temporal side, and this is more common when the pupil pupil is slightly smaller, right? So let's scotopic conditions. So this is an etiology, of course. Positive dysphotopsia is exactly not known, and various theories have explained, and due to the high refractive index of the lens or shape of the IOL, or reflectance from the artificial reflectance from the lens. those are the things attributed. But whereas the negative dysphotopsia, and as I explained to you, you see an arc on the temporal side, and especially in the scotopic condition, when the patient is awake and get disturbances. I'm sorry, I made a mistake. The negative dysphotopsia is the common that you get in the daytime, and the positive dysphotopsia you get in the dim light, in the night, especially in the light and all that part. But in daytime, when you get a shadow on the temporal side, it is really annoying. And this is the commonest type, as I explained to you, about 30 to 40% of the time. Patients and pupils are smaller. And especially when the light coming from the shadow, you see a shadow and patients tend to look into that side. The etiology of negative dysphotopsia, you can divide this into, 3 group of patients depending on the attributed reasons that negative dysphotopsias are there. The anatomical characteristic, like the pupil is small size of the pupil, smaller pupil, especially hyperopia, and the angle of kappa, or it may be related to the IOL properties. If the IOL surface is shape of the IOL surface steep or H design, and refractive power, and the refractive index, and the dioptric power of the lens. So those all are contributing factors. And then the other group that you can get this due to surgical techniques, the problems of the surgical techniques, especially the orientation of the haptic optic junction, and presence of a nasal anterior capsule. If it is little larger on the nasal side, because the light coming from this side tend to disturb by that capsule, and that can be seen. And so most common cases disappears. Most of the patient, it disappears through early period, first few weeks, but thought to be due to neuro adaptation. The patient accept that, and the patient doesn't feel it. But the same way, it may be the neuro adaptation or neuronal factors may play in generating that dysphotopsias. That's an important thing. So why I am saying the nasal capsule, there are 2 published articles on the nasal capsule, and those 2 the studies have shown when the people having negative dysphotopsia, you disturb or you do the IOL capturing, reverse capturing of the IOL, that is the capsule, nasal capsule, you push backward behind the IOL, and then the negative dysphotopsia in those patients were eliminated. So, but the problem is that it's not easy, because it causes other problems, especially because of the secondary intervention. You can give rise to post-operative complications, and especially this, you have to wait for a few weeks, just thinking that the complication will avoid, and then it is not happen over a period of time. Then only you have to redo the surgery, and by the time the capsule is adherent and all that causes other problems. Therefore, it's not a very good alternative procedure. But I have done a study on with a group of people, 3 authors here, myself, Dr. Varipala, and 1 trainee. What we have done is we have studied 456 patients in a randomized controlled trial, which was a registered clinical trial, and in 2 centers, and we recruited 456 patients, and they divided into 3 groups. And these patients, otherwise healthy people, there are no retinal problems, and the cataract grade of the cataract is material, but when there is a retinal problem, we didn't take these patients. When there is a corneal problem, we didn't take the patients into the study. But otherwise healthy people, cataractous people, we took them and divided randomly into 3 groups, A, B, C, and then we put the Alcon IOL lens at the haptic optic junction axis at 180, 90, and 45 orientation. And then we study the patient. All the any complication during surgery, we again remove the patient from the study. All normally successful cataract surgical patients we studied. And the results, if you look at the positive dysphotopsias, we got at the first day and the first week, we got about 14%. And these, I have handed over these, I have done 2 studies, both studies together. I have written a paper and handed over to a journal, and it is being reviewed at the moment. Therefore, I cannot exactly tell everything detail because it is not allowed, but I'm unpublished as unpublished data. I'm giving you the facts. So it's about so not exactly the same amount that I'm presenting, which will come in the paper. So positive dysphotopsias, you get about 14% of the people, and especially it's more common in female than the male. And I mean, that's compatible with the literature. And if you go to the world literature, it's about 40 to 10, 10 to 40% variable figures are there, the positive dysphotopsia. So in my case, it's compatible with the world figures, but it was on the lower side, 14%. And the important thing is here is a dramatic reduction over 1 month period. I have studied these people for patients for 3 months, and after that, I was planning to study for over 1 year, but unfortunately, I didn't have to do that because almost all the patients, they didn't have dysphotopsias after that, so they are happy, and it's very difficult to get them back still being studied. So dramatic reduction of this done up to less than 1% experience at the second week of a 1 month period at the end of the 1 month. And it is not bothered anymore after that. No female difference in this group. Of course, the other study, of course, I have female preponderance, but in the world literature, it says females are more common than the males. And there is no relationship with the age, but there is a statistically significant reduction in 180 orientation when this lens is used. There was no relationship between oblique, but of course, it's little more on those 2 groups, 90 and 45 axis, little more than statistically significant different this thing, and this is compatible with the public data in the world. The other study I did is I recruited double-blind. This is a double-blind randomized control trial again, 600 patients in 2 groups, A and B. And you use the same, this was done after the previous study. Therefore, I put Alcon IQ at 180-degree haptic optic junction orientation in all patients. And again, same way, complicated patients are given up. Any psychological or the patients did not take into the this thing. And the first cataract only I studied, the second cataract we didn't take. And prior to the surgery, I gave the video for group A and no video for the group B. The video explained what is dysphotopsias, what sort of positive and negative dysphotopsias, and there is no danger of that. And it is very common, which, gradually over a period of time, it will disappear. That is what I explained in that video. What happens after that? So the patient, group A people watch that video, but I don't know whether they, which groups I'm operating. So the next time the group B people, there is no video to show, and we didn't talk about the dysphotopsias. If patients get to know and ask about the dysphotopsias, we explain to the patient, but we did not recruit them into the study. So when analyzed that group A only about 3% experience dysphotopsias, and that is also mainly the negative dysphotopsias, and on the first post-operative day. And none of them was complaining as a bothering issue. That is very important thing. And in the other previous study, people were complaining the dysphotopsia as a bothering issue, but these people not. And the other thing is that I have done the visual field on these people, but in most of the time, literature says that you can demonstrate the visual field defects on visual field defects on those people. But in this case, we couldn't demonstrate any visual field defect in these people. So, and then all disappears by the second week. One came to do the refraction. So when they came for the refraction, I usually do the post-cataract refraction at the second week. And when they came to me, they all have no complaint. When it comes to the group B, is about the 43 people out of the 300 people got positive dysphotopsia, either negative or positive. Mainly, commonly it is negative dysphotopsia or a shadow on the temporal side. And then that's about 14%, comparable with the previous study. And I mean, there is a 0.7 or 0.3 difference between the two groups, but generally it's more. But most of them disappears by 6 weeks, comparable with the first study. And they are not going to, they're not having any problems. And I didn't have any secondary interventions needed to manage these patients. So this explain that if you explain about the dysphotopsia to the patient, clearly demonstrate that if you explain dysphotopsia to the patients, and the patient will accept that, and they will not complain, or probably neuroadaptation of this is more. So which is an important thing, and that's the first time that I think I couldn't find any article related to this sort of thing. So I hope that my article will be published very soon. And that's an important thing. So your explanation for the patient is important. But other factors which are very commonly available in the literature, I didn't, trying to explain because it's known to everyone. And I wanted to present these two main things. So on conclusion, dysphotopsia are very often the cause of patient dissatisfaction after complicated cataract surgery. In most cases, they are transient in nature and disappear spontaneously within few weeks. And if you use Alcon equivalence, I have no financial impact related to any of these companies, but this is what generally I put. So if you use that lens, haptic optic junction axis, if you put it 180 degree axis horizontally, and then prior explanation statistically reduces the dysphotopsias. So it's good tip. And thank you very much. And any questions are entertained. I have about 6 minutes to answer any questions. Well, there are no messages or any questions coming to the chat box. So therefore, I think we can always the questions even at the end of the session can be encouraged. So I'll give the opportunity to Dr. Chamira Bandara. He's going to talk us on, and Chamira Bandara will be Chamira Bandara is the only consultant ophthalmologist at National Eye Hospital in the field of oculoplastic. He's a qualified consultant oculoplastic surgeon, National Eye Hospital, Sri Lanka. Main bulk of the oculoplastic work in the country is handled by him. He's a very busy guy. Chamira, over to you, the microphone, to discuss on dysthyroid optic neuropathy. Chamira.
Thank you, Salvin, and the organizing committee for inviting me to do this presentation on this thyroid optic neuropathy. This is one of the most challenging as well as rewarding condition in ophthalmic as well as oculoplastic practice. So this is the content of my presentation. So the dysthyroid optic neuropathy is most severe complication of Graves' orbitopathy. It can lead to permanent vision loss. But of course, it is reversible if you made accurate prompt diagnosis and do appropriate timely intervention. So the clinician can be the deciding factor whether they will gain the vision or they are going to be permanently blind. So dysthyroid optic neuropathy is seen in 5 to 8.6% of all Graves' orbitopathy, and it can be bilateral up to 76%. Females are more, but with the 4:1 ratio, but it is less than the Graves' orbitopathy and the Graves' disease. And it leads to blindness up to 20%, mostly with the late presentation. Concerning the mechanism, there are several mechanisms postulated. The compressive optic neuropathy, the stretch optic neuropathy, optic neuritis, and the combination. Optic neuritis is not well accepted. The compressive optic neuropathy due to compression by enlarged extraocular muscles causing ischemia and mechanical injury to optic nerve, leading to impaired axonal transfer, and since the signal transmission is sort of. This leads to retrograde axonal degeneration and gliosis, which is depend on the duration and the pressure, the degree of pressure. And at the end, there will be apoptosis of retinal ganglion cells, and none of these cells has the ability to regenerate. So whatever the lost cells will not be replaced. This is the most accepted theory, and it is seen in myogenic type, this compression may occur at the orbital apex, and the degree of compression will depend on the proximity of the muscle and the size of the muscle and the apex crowding. When proximity is concerned, superior rectus is the most the closer the optic nerve, and actually some fibers originate from the sheath of the optic nerve. So the early enlargement of the superior rectus causes early dysthyroid optic neuropathy. Of course, the increasing size of the ocular muscles can lead to optic nerve compression. Apex crowding just describe the overall compactness at the orbital apex. This is depend on the bony wall, extraocular muscles, and the optic nerve, and this is an important aspect of the pathophysiology. Stretch optic neuropathy is due to the severe proptosis leading to the stretching of the optic nerve, leading to axonal dysfunction and blood flow compromisation. This is mainly seen with adipogenic type. And there are quite a few papers suggesting the existence of this stretch optic neuropathy, but there are some papers, for example, this paper by Jeffros, the stage is not that significant purely because the orbital part of the optic nerve doesn't get stretched to a level that it might cause the damage. However, Daniel and Gold in his paper has nicely explained the different level of stretch of neuropathy where the nerve is straightened and then the posterior cornea is getting coned. And this is one of my patients. You can see the optic nerve is atrophied and with the stretching. Coming to the risk factors for dysthyroid optic neuropathy, there are quite a list of findings: the old age, male gender, myopathic subtype, apical crowding, smoking, the radioactive iodine, immune response stimulants like intermittent infection, local surgery, personal strategies, and diabetic mellitus are considered as risk factors. One of the things I want to show is the male gender, because we knew it is more common among female, but as you see, the ratio with male female decrease toward the dysthyroid optic neuropathy compared to Graves' orbitopathy and Graves' disease, rendering males are more susceptible. So it's more in older diabetic male with who smoke. Successful management of these patients depend on will help you to take care of the vision. So that will depend on accurate and prompt diagnosis and appropriate timely intervention. So, but diagnosis is quite challenging because there's no diagnostic clinical features. As seen in this UGOGO survey, in eyes with definitive dysthyroid optic neuropathy, none of the visual symptoms and clinical features and investigations are 100%. On the other hand, vision can be reduced even without dysthyroid optic neuropathy. As you can see, this same finding, there are about 32% patients without dysthyroid optic neuropathy who are having reduced vision. So why do you get this reduced vision in Graves' orbitopathy? Other than the dysthyroid optic neuropathy, it can be corneal scarring, ocular hypertension, astigmatism due to muscle fibrosis, globe compression with choroidal folds, steroid-related or coincidental, like age-related and autoimmune disease-related condition can lead to vision impairment in Graves' orbitopathy. If an alternative cause are not identified, then what will happen? We will have false positive diagnosis of dysthyroid optic neuropathy inappropriately. On the other hand, if you find the alternative cause present, visual impairment might be inappropriately ascribed to them. In fact, when the patient is having dysthyroid optic neuropathy, leading to false negative. So this is quite challenging. So how do you diagnose this? So main way to diagnose is we need to find evidence to show there's a compromised optic nerve function, and you should be able to find the relationship with that to the Graves orbitopathy. So basic two parts: compromised optic nerve function based on the clinical and the optic nerve studies, and then find the link to the Graves based on the image finding and the disease status in terms of activity and severity. To confirm the compromised optic nerve function, we coming back to the same chart. We know that there's none of these findings are 100%. So how do you identify them? It's basically based on the overall picture is the most important. So clinician wisdom is the crucial thing. So going through some of these features, visual acuity, you should consider best corrected visual acuity. It is non-specific. 50 to 70% of don't have 20, 40 or more better visual acuity. However, having asymmetric vision and the progressive deterioration is more important and diagnostic. On the other hand, color vision reduction seen in 22%, and it's more red desaturation. And it is more suggestive if it is asymmetric and if it is proportional to the other features, and the color defect can precede the visual acuity changes. RAPD is seen only in the asymmetric cases and absence in symmetric cases. In these instances, slowness of the pupil light reflex should be looked for. These changes are not common, rare, such as the swelling, hyperemia, halo. It's not much useful in the early diagnosis. Visual field defects are seen in 71%, and detecting the typical pattern is important. Usually it begins with the inferior visual field due to, as we discussed, the superior rectus involvement, initially central and paracentral photoma, and progress to inferior partial or complete arc weight defect, altitudinal defect, or sometimes they can have generalized constriction with enlarged blind spot. VEP shows increased latency and decreased amplitude in about 75% of optic neuropathy, particularly in the late stage. However, this is not used as the first line of work, and it's used only when there's equivocal cases, because it is not widely available, and of course, results depend on the technique. Having confirmed the dysfunction, then we had to establish the link between the dysfunction with the Graves orbitopathy. So first, we had to find the radiological evidence of muscle enlargement pressing the optic nerve, as seen in these pictures, or having apical crowding, just overall compactness at the posterior orbit, which is a good predictor of the dysthyroid optic neuropathy with a sensitivity of 62% and specificity of 91%. Stretching of the optic nerve is seen as a straightening of the optic nerve, and the coning of the sclera is useful. And the apical effacement of the optic nerve, that is basically atrophy more than 50% of the optic nerve, is sensitive for about 80% and specific for 70%. As you see in these pictures, optic nerve is like a thread. It's compressed by the both muscles, and same as here. However, this is again coming back to the UGOGL survey. The apical crowding is seen in 95% of 95% of dysthyroid optic nerve. At the same time, in 47% of non-DON patients also have apical crowding. Optic nerve stretch seen in 33% of patients with DON, but more than that, 43% in patients without DON. So you have to be very careful when you interpreting these investigation findings. Further, to create this link between the optic nerve dysfunction and Graves, we have to think about the high-risk features of Graves orbitopathy in terms of severity and activity. So the reduced ocular motility is associated with 70% of optic neuropathy, particularly the myogenic type can associate with both compressive optic neuropathy and the ocular motility defect. Proptosis, of course, there's no correlation with optic neuropathy, particularly tight lids with tight septum have less proptosis, but more tension. As you see in these pictures, this lady has a very only multi-moderate proptosis, but if you see the back of the back with the CT scan, it will be really alarming. And the further features to help you to this develop this link is the greater rise of intraocular pressure, other congestive sign of soft tissues, resistance to retropulsion, aching pain. They're all helpful to develop the possibility of optic neuropathy in these patients with Graves orbitopathy. If you look at the clinical activity, so again, this the Google survey, the 61% has clinical activities for more than 3 inbound patients. However, in other terms, 39% of dysthyroid optic nerve neuropathy are inactive. Additional features like a rising antibody titer is associated with 96% of recent dysthyroid optic nerve, and radiological evidence of high orbital tension in terms of intracranial fat prolapse through the superior orbital fissure is seen in 20% of dysthyroid optic neuropathy. However, it is not limited to DIN. You can see that the fat is prolapsing through the superior orbital fissure into the middle cranial fossa. So having diagnosed dysthyroid oblique neuropathy, the management is quite straightforward in most of the instances. We have various options available. However, appropriate selection and the timely intervention help us to prevent the permanent defects. So the UGOGO guideline help us to achieve this. So the IV methylprednisolone is considered as first-line treatment by the survey, this group, and it shows about complete visual recovery in about 40% of patients. The dosage during the first week we suggest is the 500 milligram to 1000 milligram methylprednisolone, 3 doses, either 3 consecutive doses or every other day, particularly if you consider about the safety. After 1 week, if response is good, we can switch to methylprednisolone pulsar. If it is incomplete, of course, we can try the every other day for the second week as well. Of course, if it is worsening and deteriorating, we have to go for the decompression immediately. At the end of 2 weeks, if the response is inadequate, again, still we have to consider decompression good, we had to go for the pulses. So this methylprednisolone can be a magical drug. However, we have to be familiar with the side effects, the contraindications, and the other extreme cautions that we have to think about because some are very dreaded and can cause even death. So we have to be very familiar with that. Safe use of methylprednisolone, so we had to do a good assessment for the risk factors and all, and check all the basic features and the basic investigation, and of course, stop oral prednisolone on the day of infusion. Maximum daily dose is about 1 gram, and cumulative dose can go up to 8 grams for the cycle. And we better try to avoid consecutive day regimes and should always give us an infusion auto 30-60 minutes. In the long run, we should give proton pump inhibitors and bronch protection with the pulse treatment. Of course, we should monitor the liver enzymes, blood sugar, and the blood pressure in these patients. This lady, 45 years lady with Graves orbitopathy, coming with left eye blurring of vision for 1 month. Of course, best corrected vision is 6/6 and 6/6 minus in the left side. The color vision is less on the left side, and there was subtle RAPD on the left. Proptosis is small on the left side, and visual field show paracentral scotoma. Even though clinical activity was 1, we decided to give methylprednisolone, and the color vision improved to normal, and visual field also partially improved. The orbital decompression, again, is a well-established treatment for dysthyroid optic neuropathy, but it reduces the optic nerve compression by releasing the volume increasing the volume at the orbital apex, or by reducing the optic nerve stretch by reducing the proptosis. And it can give a prompt improvement of the dysthyroid optic neuropathy, and it can be used even in the active phase. Usually, it's a second-line treatment for severe refractory dysthyroid optic neuropathy after 1 week, or if the response is partial in 2 weeks. We don't consider decompression as the first-line treatment because first-line IV methylprednisolone is shown to be better in a small randomized clinical trial. However, you can consider as a first-line treatment for if there's a history of recent eyeball subluxation, where you have to consider decompression as soon as possible. Devoto et al. Has shown even in the chronic severe vision loss, there will be improvement of vision after decompression. So when it comes to the decompression, we do the medial wall as the first line approach, either through the nose or through the caruncle, and the next the inferior medial wall through the conjunctiva or through the nose, or deep lateral wall through the skin to achieve this. Orbital fat decompression, there's a bit of controversy about its use. Of course, after decompression, you can't stop the maintenance treatment in the form of either methylprednisolone pulses or oral prednisolone, orbital radiotherapy, immunosuppression, or as a combination, we should maintain this till we get till the patient gets stabilized. The radiotherapy take a long time to reduce the inflammation in active thyroid eye disease, so it's not useful in dysthyroid optic neuropathy. However, it has synergistic effect in corticosteroid and can be used as an alternative treatment. And it has been shown to prevent dysthyroid optic neuropathy in active graves if we given in combination. The studies doesn't show benefits of a lot of these immunosuppressive agents in active thyroid eye disease with dysthyroid optic neuropathy, rituximab, tocilizumab, teprotumumab. They are all good for the active graves, but not shown effect in the dysthyroid optic neuropathy, except few case studies where the optic neuropathy, refractory steroid, and decompression has improved after rituximab and rapamycin. Coming to this patient, 43 years old, overseas worker, diagnosed to have dysthyroid optic neuropathy, given methylprednisolone 1 gram, and then on pulses and MMF, came to Sri Lanka due to deterioration of vision. And visual acuity was 624, 660, color vision was impaired, visual field was severely impaired, there was a eye movement defect with left hypertropia, activity was 4 out of 7, and this was matters. And the scan shows severe compression and crowding of the optic nerve. And the patient underwent medial wall and medial floor decompression, first on the left side and after 3 weeks on the right side. And the best corrected visual acuity improved 6.6 on the right and 6.6 minus on the left side. Color vision 34 on the left and 38. And this you can see how the visual field has improved dramatically after the decompression. This 39 years old female, again referred by endocrinologist with active disease. Patient has been treated by the endocrinologist with pulses, came with deterioration vision. Vision was 660 on the right, 260 on the left. The color vision absent, the visual field severely compromised. There was no RFA because the bilateral involvement. Active was 5 out of 7. On top of that, 500 pulses, I gave 1 gram, 3 doses, but there was no improvement by 1 week. So scan shows severe compression of the at the orbital apex. So we did the bilateral simultaneous. At the same time, I did the both sides, the 1.5 wall decompression, and you can see the results. It can go up. Version was 6.6. The both sides. The color vision was somewhat deceptive, 15 and 11, and see the visual field improvement after the decompression. And the last case to discuss is a 47 years old patient. Diagnosed orbitopathy, was treated by again methylprednisolone by endocrinologist, presented progressive visual loss, 360 to 60 at presentation. Patient had corneal ulcer plus both dysthyroid optic neuropathy, high clinical activity. So you can see the compression of the optic nerve. So I gave 1 gram for 3 days, but there was no improvement. So did the bilateral decompression followed by maintenance of prednisolone and azathioprine followed by cyclosporine. No improvement. So considered 2 doses of IV rituximab. Still there was no adequate response. So after discussing with the endocrinologist, we started immunoglobulin daily for 5 days. Then there was some improvement. And so we continued the 6th cycle. And to our surprise, the vision came back to 6.9 in the both sides. Color vision perfectly back to normal. And you can see the visual field. So neither optic nerve, so the optic nerve doesn't give up. So I think the clinician should not also give up in this kind of patients. So finally, the screening for this type of is it necessary? Yes. Why? Visual acuity is more than 0.7 in 20% cases according to Google survey, and 30% are asymptomatic as the British Ophthalmological Surveillance Unit study. So how do you screen? You have to do all these checks in the clinic visit as well as ask the patient to do the self-check. And this is important, particularly during the active phase of the disease and after radioiodine treatment, and if the patient is subject to immune response stimulators like infection, surgery, or psychological stress. Finally, can we prevent dysthyroid optic? Yes, by controlling the risk factors. So in case of active disease, we should, particularly myogenic and one with apical crowding, we should treat with corticosteroid. And of course, studies have shown combination of corticosteroid plus radiotherapy is superior to corticosteroid alone in preventing the thyroid optic neuropathy. Stopping smoking and controlling diabetes also very useful, and must take extra precaution during the radioactive treatment, and should use steroid during radioactive treatment. And finally, the take-home message: high degree of suspicion is needed for early diagnosis, and you must do a very careful workup for clinical features and investigation to avoid false interpretation. IV methylprednisolone can be a magical drug in this patient. However, orbital decompression can also make wonders. And finally, don't give up this patient, because optic nerve doesn't give up usually. Thank you very much. Any questions?
Thank you. Yes, any questions can be, yeah, we have about 4 minutes. Any questions? Well, because there are no questions, we can move to the next speech. Well, the next presentation will be by Dr. Mangala Disanayaka. Mangala Disanayaka is a consultant ophthalmologist at Trinco Hospital in Sri Lanka, and he is going to present on role of vision therapy in the management of amblyopia. I mean, he is an innovative guy. We are very impressed the way that he is doing in a peripheral hospital in Sri Lanka, and with the available facilities and an ideal work plan when the situation in the country is considered at the moment, and a great service. It's nice to hear to you, Mangala. So over to you.
Thank you very much, Dr. Salvin, and I thank the organizing committee for giving me this opportunity to present in this forum. I'm a little trouble in sharing my screen. It doesn't allow me to share the screen. Yeah. Okay. And
Right, we can see your slides, Mangala.
right. Is it all right?
It's all right. It's all right. It's shared, but it is on the not on the slide mode, presentation mode.
Okay. Okay. Thank you very much. So my topic today is role of vision therapy in the management of amblyopia, especially in a peripheral eye unit, as Dr. Salvin told earlier. So I'm working in a peripheral eye unit, so it'll be handy in a place like that. So what is vision therapy?
Mangala,
Yeah,
can you switch on to the slide show mode in PowerPoint?
Yes, right. Okay.
Right, fine, good, very good. Right.
Thank you. Right. So what is vision therapy? Definitely it's not a new concept, and it has been there for a long time, existing in different ways. It's apparent that optometrists in 19th century practiced it. But in the early era, there were no proven benefits and they didn't get good outcomes. So hence that it was not very popular. However, it took some time for the people to understand the principles and benefits of it. And therefore, it is now being developed as a new science, probably with a new home. There's no definition as such for vision therapy. But in a nutshell, vision therapy is a science of achieving clear and comfortable vision by using non-invasive techniques. So that non-invasive word was the beauty. So vision therapy relies on the neuroplasticity of the brain, of course, which is more in the youngsters than adults. That doesn't mean that adults can't have this treatment, but you get more good results in youngsters. So there are a lot of users in vision therapy. There are ophthalmological users as well as non-ophthalmological users. So we are mainly concerned about the ophthalmological users for the time being. So first one is the amblyopia and the screens, convergence insufficiency. And it says that it can be used to improve peripheral visual fields, especially functional visual fields, and to improve hand-eye coordination. So we are mainly concerned about the amblyopia as per today's topic. So it's very important to understand that amblyopia is not just reduction of vision, because it has other components as follows. These amblyopic patients can have reduced acuity, reduced contrast sensitivity, reduced color vision, reduced sensitivity in the peripheral visual fields. So that is called functional visual field loss. And impaired binocularity, impaired accommodation, impaired tracking and focusing, and impaired hand-eye coordination. So that may be the reason if you are going to correct the acuity, patients might not be very happy because other parts have not been addressed too. So vision therapy helps us in addressing the other part of the amblyopia in its management. So the treatment, if you consider, the refractive correction is the must. So lenses and prisms are being used, different lenses, whatever the way, to correct the refractive correction. So then the occlusion, because these amblyopic eyes are in a state of suppression. So it is very, very important to break this suppression. Still, the most anti-suppression treatment is occlusion. The eye patch are the commonly used, but there are foggy glasses where we can use, and the Bankerter occlusion foils. So they are graded plastic sheets where they allow certain amount of light to go into the occluding eye. So it doesn't allow for that light to go into amblyopia, especially in kids. And occlusion contact lenses for toddlers. So then comes the vision therapy treatment part. So vision therapy treatment part has two arms. One is the orthoptic assessment and exercises. The other one is a computer-based programs. So there are four parts I have chosen for the discussion. The one is heart chart, Marsden ball, vectograms, and syntonic phototherapy. So those are the basic things. I come to them. The other one is the computer-based programs. The Marsden ball. So it's very, very simple structure. A ball hanging at the end of a string. So, so there are different Marsden balls are being developed or introduced. So actually, Marsden ball is a different subject because it helps you to increase the acuity, to hand-eye coordination, to the balance, a lot of things. Especially when you are standing on a balancing board and doing this, hitting a bat with the bat on the Marsden ball, it's not that easy. And especially it has been used to train the sport, sort of some sports like, especially in racing cars. So people do that to train their hand-eye coordination and the other skills. The heart chart. So heart charts comes in different sizes, but different ways. But there are two parts: a bigger chart and a small chart. So you have to keep the patient in a certain distance and give a smaller chart. The patient has to read from the smaller chart and the same line from the distance chart. So you have to keep on doing it quickly, and you can change the charts. So that means the bigger chart has a different pattern and the smaller chart is having another pattern. So this way, it can be used to increase the acuity as well as the accommodation. The heart charts and the Marsden ball can be used uniocularly as well to improve uniocular amblyopia. So on the right, it is our orthoptist showing how to do the heart charts in our lab. The vectograms. We all know about the vectograms. Vectograms are there to increase the stereo acuity. Right? So when the people are not having stereo acuity, how can they use the vectograms? You can see this. So the two images, you have to superimpose them. But by patient with a good binocular vision, it can be easily done. But if they don't have, so there are numbers in it. If you can see, so there are different numbers, and there are the same numbers in the other part as well. First of all, they have to superimpose by using these numbers. So that will induce a small disparity, retinal disparity, which will induce the 3D view or stereo acuity. The syntonic phototherapy. So actually, the ancient Greeks started this phototherapy in the history. So now it has been developed, and different colors people have found that different colors can cause different effects. So like blue light. So it makes you relax, and it induces the convergence. So it has been used to treat the amblyopia as well as in squints as well. So so this is a machine which delivers the photo or the light, And I think these things are not available in Sri Lanka, but still you can use a white light by using these colored glasses or monocles like this. The same effect can be done. So the other thing is the computer-based programs. So this is the program that we used in our lab. So I will show you some videos because there are it's like a computer games. So the kids will like that, and that will enhance the different effects in the eye. So the most important problem in amblyopia is the suppression. So whatever it is, we have to break the suppression. So these computer games or the programs can be used to break the suppression. So here we have to use the two goggles, red goggle as well as green, blue goggle in front of each eye, red in front of right. So then this ball will flow and it will fall on the bottom, and you have to move this paddle to hit the ball so it doesn't allow it to fall down. So likewise, so you have to do it for a long time, and it takes a lot of time to get the effects. So I'll show you another video where shapes can be used to break the suppression. So there are shapes appearing, so red and green, you have to count them. Right? And give the count here. So if they are unable to see, you can flash red or flash blue. So that flashing will help to break the suppression. So this is to improve the binocularity. It's called binocular pursuits. It will show 3 lines actually. So the outer line and inner 2 lines. But you have to fuse this one so that you'll be seeing 2 lines instead of 3 lines. So I mean, you can do it at the very early stage. You have to keep on practicing and let the patient practice it and do this one. And after fusing, it will start moving like this. And you have to follow. The patient has to follow keeping the fusion. So when they see 3 lines, they have to stop it and get it corrected again to see 2 lines, then start it again. So likewise, you practice. So there's another one, it's called computer versions, so jump vergences. So there are different images are appearing, same image in 2 colors, red and blue. So you have to move it and make it as a one image. So as shown in the video. So they have improved versions like double versions, where there are 2 sets are coming like this, and you have to do it quickly. So first set we have to do very quickly and go for the second test, and the machine will count the time that is taken to do the exercise. And there's an automatic mode where the images are moving automatically, and then you have to fix them. So likewise, there are stepwise improvement. So this is another one, this little advanced one, where you have, so if you see, there's a red one and the blue one here. So they have, so outline is the same, but the inner lines have little disparity. You have to fuse them and make it a one image. Then there will be flickering lights here. Same time, there are letters here, red letter and the blue one. So you have to see them as well. So this is not a very easy one, but you have to practice the simple one, and stepwise, we have to go stepwise and increase the acuity as well as the binocularity. Because now they say the best way to treat the amblyopic eye is to tie it with the good eye and drag it with the good eye, rather than trying to push the amblyopia eye alone. So that's why they have developed this kind of the exercises. So these random dot stereograms, we all know about it. So there are different shapes will be appearing in the center. So this is a bit of an advanced one. You have to practice the basics one and come into the advanced one. So you have to the person has to identify the shape from this one, and if they don't know, you have to pick the don't know. So likewise, so then they will that machine will be shown easier one. So those are the basic things. So there are advanced versions like visual thinking, and so on and so forth. So I have taken 2 examples to show you. So this is called visual thinking flipper. So that will show you an image. So it will be marked down here. So then the images will be appearing. When you get the image that you have selected, you have to click it. Likewise. So this is a simple one. So there are still complicated ones where the machine doesn't show the image that you have selected. And you will be shown some images and the question will be asked. So you have to match this one. So likewise here. Then again this question appears and you have to choose among the things. So there are so I have selected few because there are about 200 odd exercises there in computer-based programs. However, still the vision therapy is an adjuvant therapy, and it's time-consuming and it gives you variable results. And it might take long time to train a patient as well. And outcome mostly dependent on patients and especially the parents' determination and the dedication. And it might not be rewarding as well sometimes. But it's worth trying as it is non-invasive and gives you the patients to recover, to get the best chance to recover in this condition. So that's all I got to say. This is a very simple presentation. I just want to introduce kind of vision therapy and what the things that we do in periphery to influence that this can be done in simple way. Thank you very much.
Thank you, Mangala. Thank you very much, Mangala. Any questions? There are no questions on the chat box. We will wait for a few seconds. I hope the technical team has connected to the audience. There were people listening to our topics. I went into the audience as an audience member in the audience. Mangala, people were listening. But anyway, because there are no questions, we have enough time, about 6-7 minutes more. Okay, we'll move to the next speaker. He is Dr. Amila Jayaratna, and he is at the moment in United Kingdom, is undergoing his post-MD training, and it's not easy for him to join at this moment, early morning in UK. Anyway, thank you very much, Amila, for accepting our invitation from the college, and you can start the talk now.
Can you see my sharing?
Yes, we can see clear.
Okay. So, so this is about updated NICE guidelines for the glaucoma management and concerns for starting treatment for glaucoma. Okay. Diagnosis mainly on the recommended parameters. We'll discuss in a moment what the parameters are. Forward. Yeah. And consider the life expectancy of the patient. So the management of glaucoma starts at the doorstep when the patient comes into the room, having an idea about how long he has from today to go forward. And risk factors to consider, introducing available treatment options for that particular glaucomatous condition, and getting patients enrolled in their own eye care. Patient's mental capacity to make a decision, we should consider that as well, and follow the guidelines and high quality study results. For an instance, if you want to think about managing non-intensive glaucoma, we can make use of collaborative non-intensive glaucoma study. And if you want to manage open angle glaucoma, we can go for early manifest glaucoma trial. If you want to know how much the pressure should be reduced in a ocular hypertension, then we can make use of OAT study. And if you want to decide whether the cataract should be taken out of a primary angle well closure or a glaucoma, whether the patient is having 6.6 or 6.5, then we can make use of eagle study. And most of the things what I would say in this session will be what we already know, but it's always better to know what is said exactly in the guidelines, because it's always good to practice evidence-based medicine, because as far as NICE guidelines are concerned, we know that they are created by a panel of members to be implemented in the entire NHS. And I hope at least there'll be few new points for our daily vocabulary to get from my talk. But if I say something away from guidelines, I will tell that. And also, especially in the management of combined pathology, which you quite often see, it's always better to adhere to guidelines rather than using our wisdom, because it will be otherwise stopping halfway and altering the cooking of the management of patient. And we can customize whatever the guidelines say. We need to customize our practice according to the resource availability of the country that we are practicing in. Well, what are the parameters? Central visual field assessment with standard automated perimetry, basically with CETA standard 24/2 Humphrey visual field, and optic nerve assessment, mainly the morphology of the nerve retinal rim in dilated fundoscopy. But if we have optic OCT, we can make use of that, but we can't replace dilated fundoscopy. Intraocular pressure by Goldmann applanation tonometry, and anterior chamber depth and angle assessment, preferably by gonioscopy. But if the clinician doesn't have the skill, or if they don't have a 4-mirror size gonioscopy, which is the best, then we can go for one Herrick test or just anterior chamber OCT. And last but not least, central corneal thickness. At the assessment guidelines say, do as much as possible to minimize the transmission of infections, and machines should be well calibrated at all the time. Diagnosis of definitive glaucoma is made by having visual field defects in Humphrey visual field, which are compatible with the nerve retinal rim loss, and visible optic nerve damage in the first presentation, or we see kind of a progression of nerve fiber layer loss in subsequent visits. Other factors to consider: how much the central corneal thickness is away from 550 microns. It means even though there is no proper method to tell how much the intraocular pressure is low or high in thinner and thicker corneas. Some schools I have thought telling that 1 digit to reduce or add when it is away 20 microns away, but it's not an exact method, because it's just work of histories of the cornea and family history. Before starting the treatment, better consider repeating the visual field and intraocular pressures that is mentioned in the guidelines specifically. Extra factors to know before starting treatment: drug allergy, especially to preservative, because we can straight away start preservative-free drops. And dry eye, again, preservative-free drops would be ideal. Comorbidities affecting the individual anti-glaucoma treatment that we all know. For an instance, if a patient is having occasional asthma, whether to start timolol or not. Okay, so the treatment will be discussing 4 slots like this: ocular hypertension, and open angle glaucoma suspect, open angle glaucoma not at advanced stage, and advanced open angle glaucoma. No treatment is given for ocular hypertension if the patient does not possess a lifetime risk of visual impairment. So we can advise them just to get themselves followed up somewhere. But we need to discuss benefits of treatment and risks of no treatment. That is where the make use of studies comes. For an instance, if a patient comes with an intraocular pressure of 27, we can say, If you don't start treatment, there is a 9.5 chance of getting glaucoma by 5 years. If you start treatment, still there is a 4.4%. So maybe a 50% reduction of the chance by 5 years, but still you have 90.5% chance not to have glaucoma even you don't treat yourself, your eyes. Treatment of ocular hypertension is started if the intraocular pressure is equal or more than 24. The first line treatment in the guideline is selective laser trabeculoplasty, and then a generic prostaglandin analog for who choose not to have SLT initially, and if you feel like SLT is not treatable for an instance, even it's not an absolute contraindication in pigment dispersion or very thick trabecular meshwork, especially we seen in Asians or in Africans. If they need interim treatment till we offer SLT, if you can't offer the SLT on the same day, and even the FLT is given, but your intraocular pressure lowering is not sufficient, then at the very first anti-glaucoma prescription, guidelines say teach the correct technique. We as clinicians may not have time to do that, but we should allocate somebody who can correctly do it. It's not at a stage where the patients are not responding to our treatment to see whether they are using their correct technique. Treatment for who cannot tolerate the first given prostaglandin analog or whose intraocular pressure lowering is not sufficient, then we can go for alternate generic prostaglandin analogs, beta blockers, non-generic prostaglandin analogs, carbonic anhydrase inhibitors, sympathomimetics or mitotics, or a combination of above. And if the patient wants to stop the treatment midway, thinking that, oh no, I just want to stop it, then we can again discuss the same thing which I told a minute ago. Treatment of suspects of chronic open-angle glaucoma, only if the pressure is more than 24 or only if it is 24 or more, and again possesses lifetime risk of visual impairment. Otherwise, we can advise them to get followed up. If the patient wants to stop the treatment, again the same, while they are on treatment. And the treatment of non-advanced open-angle glaucoma or open-angle glaucoma suspect whom we think better to get treatment, then the first-line treatment, again, selective laser trabeculoplasty. Then a generic prostaglandin analog for who, the same thing, what we discuss in ocular hypertension. And if they are not responding, then check for the technique again. And even the intraocular pressure is satisfactory. If the nerve retinal rim loss or the visual field loss is progression, then you should check for the technique again, because at the time we check, pressure might be normal with a diurnal unjustifiable variation. Those with open-angle glaucoma or suspicion who cannot tolerate first given PGA, then we can start beta blockers. Here in the guideline, they don't say to start another prostaglandin in the same class or a non-generic, because studies have shown if it is not responding, diagnosed open-angle glaucoma is not responding to another prostaglandin if they are not responding to the first one. Then beta blocker, carbonic anhydrase inhibitor, sympathomimetics, and mitotics, the same way. And also we can offer the same topical management if the IOP control is unsatisfactory or the glaucoma is progressing. Okay. If more than 2 therapeutic classes are used in topical medication, then we need to offer selective laser trabeculoplasty, again, if they choose not to have it initially due to some reason. Glaucoma surgery, phacoemulsification per se, or with or without viscogonioplasty, with or without microinvasive glaucoma surgery, minimally invasive glaucoma surgery, or with or without various types of stents, or trabeculectomy. Guidelines say with MMC augmentation, but you can cater it to your need. And cyclodiode laser. Treatment of advanced open-angle glaucoma, the first line is glaucoma surgery with mitomycin C augmentation. Generic prostaglandin analog for interim management till the trabeculectomy is done, And thirdly, selective laser trabeculoplasty of pharmacological management, as we discussed earlier. Okay, so throughout this guideline, I think you saw that selective laser trabeculoplasty has a big voice there. How it came? Because they provide a better diurnal intraocular stability with the pores that we iatrogenically made in their trabecular meshwork. And cost effective, very cost effective in long-term management. Even the initial cost is very high, and could avoid or reduce, the drops or reduce the number of drops which could be otherwise needed. Relatively a safe procedure. Better to think whether it is really applicable to use in conditions of pigment dispersion, but level 4 or 5 evidence shows that sometimes it works really well. They can have some intraocular pressure spikes, which you can manage with post and pre topical medication of IOP lowering drugs. May not work in some people, unfortunately, and within 6 months, 15% of the people, patients, they may need another SLT treatment. Effects may wear off by 2 to 4 years, but they can hold up to 6 years, surprisingly. Need skills hand for better results, and at the same time, you need to customize it according to the availability of SLT. For an instance, in India, I think most of the audience will be from India and Sri Lanka. Now, in India, there are institutional based SLT machines everywhere, but in Sri Lanka, we are still in a developing country, but our glaucoma interest group, college and the ministry will work to have some SLT machines. For the time being, we don't have any. I think one we have in vision care. I don't have any financial interest, but that also the launch will be next week. Okay, so this all about SLT came after the study called LIGHT. It's a classic example how bench to bedside research could have a robust impact on patient management, in the same words of Professor Gus Gazzard, who's the first author of this study, and American Academy of Ophthalmology Preferred Medical Practice, and also the European glaucoma guidelines were changed because of this study. It stands for laser in glaucoma and ocular hypertension. Okay, few about LIGHT study parameters. It was a randomized controlled trial done in 6 centers, so multi-center study, and open angle glaucoma and ocular hypertensive patients were included in the study, and it looked at how SLT followed by eye drops versus conventional topical treatment is doing. 16,000 odd patients were assessed initially for the eligibility, but 718 treatment new patients, it's very important, randomized to the trial, 356 in SLT arm and 362 in eye drop arm. Checked 4 things in the study: health-related quality of life and cost, and intraocular pressure control, need for the eye drop and the need of eye drops in time to come, and the patient tolerance of the treatment. 3-year results says, it means there's a 6-year results as well, but I'll tell only about the 3-year results now. Had glaucoma progression in 5.8% of the patients in eye drop group, whereas 3.8 in SLT group. And out of that also 74% of this SLT group who had the glaucoma progression had a kind of good iopic control at 3 years. And none in the SLT group required surgery to lower intraocular pressure, whereas 11 in the eye drop group needed surgery. Near 75% in the SLT group was drop-free at 3 years. And 6-year results says it's 70. It means if you give SLT treatment to 3 people, 2 will be without drops at 6 years. Really amazing, isn't it? EQ-5D questionnaire shows some non-superiority, maybe because of the shorter period of the assessment, because glaucoma is a disease which goes throughout the life, maybe for decades, sometimes 4 or 5 decades. Better tolerance noted in SLT in the study. Finally, SLT group had less drops, less hazard. I mean, patient doesn't want to find where the drop is and to put drops every day. They can enjoy their vacation or holidays out of the country without thinking about the fridge to cater their topical medication, and less side effects of the eye drops as well, and less progression, less glaucoma surgery. Okay, so about the light study, they're not mentioning in the NICE guidelines because they can't do that, because just one study when it's a high quality study. So why I did tell about it is because it has a very good impact, robust impact on the NICE guideline change. Back to the NICE guideline, last few slides here. Reassessment in unsatisfactory intraocular pressure control to review, we should review by 4 months' time. If it is together with a clear progression in diagnosed open-angle glaucoma, we should review less than 2 months. If the IOP satisfactory is good, then the review mattered by whether the conversion to open-angle glaucoma is there in suspects or ocular hypertension. If the conversion is uncertain, we should review by 6 to 12 months. If there is no conversion, then we can delay up to 12 to 18 months in suspects and 2 years in ocular hypertension. So it means if the ocular hypertensive patient having good control, we can see by another 2 years' time. Reassess unless they stop their treatment or do something else. Reassessment in satisfactory intraocular pressure control in open-angle glaucoma, it depends on the progression. If it is stable, we should review by 6 to 12 months if the features are advanced. If it is not advanced, again, 12 to 18 months. If the progression is clearly there, or if it is not sure, we should get the patient back by 2 to 6 months' time. In other words, in assessment of the open-angle glaucoma, if the intraocular pressure is satisfactory, 2 to 6 months. If not satisfactory, less than 2 months. Few additional considerations in glaucoma management, which is set in the guideline, NICE guidelines. Warn about the blurry vision following dilated funduscopy in examination without giving a surprise to the patient. Patient informing the driving authority themselves about the considerable visual acuity or visual field problems they encounter with glaucoma, and give low vision care if they have because of glaucoma, and also give some information to the support groups they could get hold with, and whom to contact urgently as far as glaucoma is concerned in the eyes or drug-related problems, and also clearly tell them what's the mechanism of the arrangement of the next appointment for them without just telling come by 6 months. We should clearly tell them what's the mechanism of the appointment. Thank you.
Thank you, Amila. Any questions from the audience? There are no questions in the chat box, Axel. I think we are quite early, but it was very nice presentations from all speakers. Mangala, can you switch on your camera as well? Yeah, it's a very nice presentation by everyone. We'll wait for a few minutes to see whether any questions. Well, I don't think questions are there. Thank you very much once again on behalf of the college. We all presented to this All India Ophthalmic Association Glaucoma Conclave, and we did our best to represent the college, and I'm sure Professor Namrata and the others will be happy with, pleased with us. And if there are any questions, still we can encourage. Yes. So we will. Any comment from the speakers? Anything to comment, Shamira?
And yeah, thank you, Salvin, for moderating the program. It went well, and we could do the program as planned and on time. And all topics were kind of interesting. I hope that everyone got benefit from that.
Mangala?
Alvin, I think it's a great pleasure to do the presentation. This is, I think, my very first presentation like something like this. So I thank our college for giving the opportunity to be us who are working in the periphery as well. The topics are very interesting, and that's very interesting what you presented, because sometimes it's very difficult for the people to make them understand what the dysphotopsia, especially the where I work. So sometimes we have very good vision, and they come and complain. So I think this is a part that we should be addressing, even in our consent forms, actually. So I'm just thinking about it. So I have so we have consent forms. So I should add this to my consent form. I'm just thinking about it. You might get thing. And Shamira's one is a very good one as well. So we all get all of a sudden. Shamir is very helpful to the peripheral surgeons. Anytime we can call him, and he's give the fullest support. So he never say no. Anytime. So that's, thank you, Shamir. I'm taking this opportunity to thank you as well. And Amila is my friend, so we work together in same district as well. And it's also very interesting. So I learned few some points are very interesting. So we should incorporate that to our practice as well. And I thank you very much to all of you, and to the Aios as well, giving this opportunity to us. Thank you so much.
Amila, do you want to comment anything?
Not really, sir. I think we need SLT machines in Sri Lanka, isn't it? Because it has comes to for the first page in the guidelines now. So
up to you all guys to come and start the program.
And also, Dr. Shamira, is a great pleasure, because I get advice from UK, I think, because I'm calling, he's answering phone. Thank you very much. And
yeah,
because
yeah,
whenever I come across a quite tricky condition, I call you. And I think Dr. Mangala will get a lot of calls all around Sri Lanka now, because it's some part that we don't usually look into, and we just tell our optometrists or their parents to do that, but to do how it is exactly shown by Dr. Mangala. So I think we need your inputs to manage our patients as well when I come back to Sri Lanka. Good. Thank you.
Okay. I think even though we have 8 minutes more, we can bind it up. Any comments? Anyone else want to talk? Okay. So we will wind up. Thank you once again. On behalf of the College of Ophthalmologists of Sri Lanka, I like to thank All India Ophthalmic Society for giving this opportunity for international conclave. And thank you very much. And we hope to join similar meetings again in future. And we greatly appreciate the support or cooperation given by the Aios Continuous to Sri Lanka College. Thank you very much. Thank you, everyone. And thank you for the audience for tolerating our presentations. Thank you.
Thank you very much.
Thank you very much.
Thank you very much.